All right, well, let's go ahead and get started. I just want to thank you all for being here today. Um, we are talking about assessing your telehealth capacities and developing from where you are, specifically for our palliative care initiative at the Washington Department of Health. We have two experts that we're going to ask some questions to. This will be a very conversational style. I'll ask them some questions, they'll answer, and then we're going to stop and have a case presented. In the middle of all of this, if you have questions, please chat them in the chat box at the bottom of the screen, and then we'll save them for a couple different times during the webinar that we will stop and answer questions. So with that, I will go ahead and ask Tammy Arndt to introduce herself.
Good afternoon, everyone. My name is Tammy Arndt, and I am the Director of Northwest Telehealth here in Spokane, Washington. Northwest Telehealth is a division of Inland Northwest Health Services and an affiliate of Providence St. Joseph Health. I'm also the Eastern Washington board member for the NRTRC, which is the Northwest Regional Telehealth Resource Center, and a certified telehealth program manager. I don't know if that makes me an expert, but I think all of my expertise comes from helping many people get programs started. So thank you, Bonnie.
Thank you, Tammy. Our other speaker today is Denny Lorden. Michael, has Denny joined yet?
I'm here. Can you hear me okay?
Yes, we can hear you, Denny. Can you go ahead and introduce yourself, please?
Excellent. Good afternoon, everyone. I'm Denny Lorden. I'm the Telehealth Partnering Manager for Providence St. Joseph Health. And in that role, I help our regional entities develop new telehealth programs and initiatives. We call those regional innovation programs. And then we also work with hospitals to see if some of our enterprise telehealth services would help them solve some of their issues. So we have programs like stroke, mental health, remote patient monitoring, ICU, those sorts of applications. And then I'm also fortunate to participate with several state telehealth collaboratives, such as the Washington State Telehealth Collaborative and the Montana Telehealth Alliance. So we work on trying to address issues like reimbursement and licensure and remove the barriers that sometimes get in our way or often get in our way to advancing the field of telehealth.
Thank you, Denny. Our third speaker today is from one of our critical access hospitals, Pullman Regional Hospital. It's Deb Watson. Deb, can you introduce yourself, please?
Yes, good afternoon, everyone. My name is Deb Watson. I'm a nurse and currently working as a clinical project manager here at the hospital with one of my first projects as the palliative care services here at the hospital. And I'm also the clinical coordinator for the Department of Health initiative. So thank you, Bonnie.
Thank you. So I'm going to facilitate and start by asking a few questions. You know, I just realized I don't know if I introduced myself. I don't think I did. I'm Bonnie Burlingham. I'm from the Washington State Department of Health Office of Rural Health, and I work with the State Office of Rural Health, working on several different rural community initiatives and with hospitals and clinics. So, so thank you again for being here. I'm going to go ahead and ask our first question to Tammy today. Tammy, if a facility wants to set up a direct-to-patient telemedicine service, what are the first steps that it needs to take?
Thanks, Bonnie. So there are many steps involved. We try to make it simple as possible, but the first thing we always ask any program or project, group of people who come to us is, what problem are you trying to solve? That really helps us go in a direction. So are you trying to improve access to care, improve the quality of care and the outcomes of your patients? Are you looking to improve staff efficiencies or patient convenience? So identifying the problem that you're trying to solve is always the first step for us. The next thing we ask is, what kind of capacity do you have to initiate a new program, not only with your staff, but also the providers, the folks in the clinic, the patients, the family members, and also just buy-in, because this is a change in workflow at any clinic. So it's kind of a look at not only capacity, but do you have folks who are interested in actually changing the way that they're delivering care? The next thing we always want to address is reimbursement for the services that you're offering. Historically, for telehealth, there have been issues with reimbursement, and it's not always been an equal playing field. So when it comes to new services for telehealth, we want to make sure that it's a sustainable program by making sure there's some kind of reimbursement. The next thing we'll ask or explore is what the consult requirements are. So not every consult is appropriate to do direct to patient in someone's home. So one, you have to look at in terms of reimbursement, who the provider type is. Is it a physician, a nurse practitioner, a social worker, a registered dietitian? Who is it who's providing the services, and are they able to be reimbursed for it? Are there requirements for the CPT code like vitals? Can't you do, if you can't do the vitals from the patient's home, maybe that's not the correct kind of consult to be offering. And then for reimbursement, it's also important in terms of payment where the provider and where the patient is located. So those are considerations when you're starting something up. Back in the day when we first started with telehealth and telemedicine, the number one conversation seemed to be technology. So can people do it? How expensive is it? Fortunately for today, that's one of the last things we worry about, because everyone has the kind of capabilities today to really receive services. But having said that, there are still technology requirements. So for a telemedicine consult, you want a synchronous two-way audio and video connection. So you need some kind of a device that has a camera, a speaker, and microphone. It could be a cell phone, it could be a laptop, it could be a tablet, but you do need to make sure that you've got that capability to do a two-way connection, which means that you need an internet service of some sort that's capable of supporting synchronous video and audio two ways. So when we get started, that's kind of the top 5 things that we'll kind of explore before we go any further.
Thank you, Tammy. Denny, do you have additional comments?
I'd say that Tammy stated it quite eloquently. One of the things about telehealth is it's extremely complicated with all the moving parts and pieces and logistical things that we have to address and make sure we have covered. So it's often helpful to sit down with a program requester and go through an initial conversation about what their problem is that they're exactly trying to solve. And oftentimes we uncover some of the things, whether it be licensure, reimbursement, or whatever, but it's good to have that initial conversation and really trying to explore what the problem is that we're trying to get to.
Thank you, Denny. So, with that, what are some of the common problems or scenarios that people are trying to solve using telemedicine?
So I guess I'll start with this one. I think that mostly what we've seen direct to patient is follow-up care. So think about all of the people who are in rural Eastern Washington, for example, and maybe their specialist, whether it be for cystic fibrosis or movement disorders, whatever it happens to be, their specialist is in an urban center and they're traveling to get there. And perhaps it's a struggle. Sometimes people like to come because they can go shopping, but oftentimes with a compromised patient, especially in this set that we're talking about, that's a struggle and it's a burden, right? So oftentimes people are trying to, with telemedicine or direct-to-patient consults, to create a touch point in between the regularly scheduled appointments to keep in touch with the patient to make sure that their outcomes are good, that they don't readmit if it turns into something that needs to be closely managed back into the hospital. So it's basically to keep in a more convenient, economic way connection with their patients.
Thank you, Tammy. Denny, do you have anything to add on that one?
Well, I think that one of the things that we do in addition to increasing access and increasing convenience for patients is really have a way to also impact cost savings. So I'll kind of give you an example of a more extreme example of telehealth. This is a case where we provide connections to the parents in the home for neonatal patients that have severe cardiac issues. And so when these patients are discharged initially from the hospital, they've had a heart surgery and they go home and they try and put on weight on the child for successive heart surgeries. And these are infants that are severely at risk of issues that arise, and parents often panic in those situations. So typically what happens now is the nurse, the cardiac nurse, will call the patient, check in on the patient, see how their weight's doing, their respiration, vitals, demeanor, and all those sorts of things, but it's not something you can easily visualize over the phone. So by utilizing video to do that, oftentimes we can help the patients feel confident that the child's okay. The provider can have a look at the child, maybe look at their pulse ox or their color or whatever, and determine whether or not that child might need to be transported in. So on several instances recently, an infant developed a fever, and the parents panicked and they activated life flight. So you can all imagine what that costs. It's approximately $35,000 to $50,000 to transport a child, and some of those were, quite honestly, unnecessary transports. So we really have an opportunity to impact the cost of care, as well as keeping parents and children home comfortably and knowing that they have a backup support system and doing a regular check-in.
Thank you, Denny. So those are some great scenarios, and you guys kind of mentioned some of the problems you can solve. What are some of the problems that telemedicine can solve for, and what are some of the problems that telemedicine cannot solve for?
So we do, when it comes to direct-to-patient care, we have worked closely with programs to get successful implementation. And for us, that has been doing technology certifications, testing with the patient from home to make sure that they understand how to receive the link, how to access the software, and what the best protocols are for seeing your provider at home. We can solve for those pieces, but sometimes we can't solve for a patient who's not very compliant. So we have found that if they're struggling to come into the clinic, sometimes they'll struggle to still come to their appointment via video, and that the issues are really not about the technology or wanting access. It's just human behavior. So again, some of I've had programs that have said, we're trying to solve for these people, but it won't solve for everyone. There's a variety of reasons why somebody may not be a good candidate for direct-to-patient care, and this certification process kind of sorts through a piece of that. Denny?
I'd say that, as Tammy mentioned, probably connectivity for direct-to-patient applications is one of the biggest challenges that we have to address. As you can imagine, patients live in very rural communities where access is a challenge. The other thing that is challenging is, if sometimes we just don't have the ability to get reimbursed for these programs, and it takes a lot of time and effort to roll these out and make them sustainable programs. So if we don't have a mechanism for which we can do that, we really need to think twice about whether or not this is something that we want to invest in. So that's probably one of the most particularly challenging things, is looking at the business model and seeing what kinds of things are impacted by that.
Thank you. So we're going to talk about the business model in just a couple minutes, but before that, there was one other question sort of related to all of this setup and trying to figure it out, and that's the question of HIPAA. How does HIPAA fit into this?
So I'll take that first stab at it. So you want to make sure that when you're delivering services via video, that you have encrypted, secure software. So when we talk about software, we take a look at what its capabilities are in terms of security and privacy. And the number one thing that you need to do when you're working with a vendor is make sure that you have a business associate agreement, which requires reporting the HIPAA rule for reporting any breaches. So that's step one. Make sure you get a BAA with the software that you're using. You want to make sure that the software is encrypted. You want to make sure that you have a plan for how you're delivering the link. What we have found is that that's one of the biggest issues of privacy, is how is the patient going to click on the link in a secure environment so that it's not on the public internet or on personal emails. And just to address it, what we've found is that most facilities have patient portals associated with their EMR. And there is a way in any EMR where you log in as a patient where you can have a message and you can place a link in a message with directions. And that's a secure place for, again, the patient to come into your healthcare environment and receive connection information to get to the provider. Danny, anything else?
Nope, I would recognize that Tammy is by far the HIPAA queen, in my opinion, so I'm not even going to approach that.
Thank you both. Well, Denny, the next question is really directed at you. What are some of the billing and reimbursement challenges in setting up the telemedicine program, and what are some of the solutions that you have found?
Yeah, I would say that there's probably two aspects of telemedicine that are particularly challenging and most complex, and one of them is reimbursement, and the other is legal, regulatory, and contracting. So when we talk about reimbursement in our world, we're basically talking about three buckets: Medicare, Medicaid, and commercial insurance. One of the most challenging areas of reimbursement is related to CMS. So they put a lot of roadblocks in our way. They restrict what services we can bill for and what CPT codes we can use. They restrict where a patient can be. Primarily, they need to be in a rural location or a HPSA or a health professional shortage area. They can't be in a metropolitan statistical area or urban area. And then they also restrict what types of providers can actually do telemedicine and get reimbursed for it. So a number of providers like therapists, as an example, speech, OT, and PT are not reimbursable by Medicare, nor are pharmacists or geneticists. So those are the common ones that we run into. And we're constantly working with CMS to kind of open the door a little bit wider to think about other providers being allowed to be providing these services and reimbursed. So CMS, as an example, this year there was a federal bill passed called the FAST bill. And what it did was it allowed stroke providers to provide services in metropolitan areas. So as an example, if I'm doing telemedicine in Portland or Seattle or Spokane, and I'm providing telemedicine services into a larger facility, I can't get reimbursed for that service. But the FAST bill allowed that to take place in urban areas. So that was the first step where they opened the door to having services being able to be delivered in metropolitan areas. So we're working to expand that with other services like mental health, which is a huge need in most communities. And so Medicare is one of our most challenging areas. Medicaid, on the other hand, most states have a policy for Medicaid reimbursement, and it varies by type of service or by type of provider. So you really need to understand and take a look at a particular state that you're operating in and see what their guidelines are around fee-for-service or maybe managed care telemedicine. The third one is related to commercial insurance. So in our world, we have in many states now what we call coverage parity for telemedicine. In other words, if I can get paid as a provider for doing telemedicine face-to-face, I, as an insurance carrier, now have to be reimbursed for doing it telemedically. So that's coverage parity. What's really important to note that is that's not necessarily what we call payment parity. In other words, am I going to get paid at the same rate as I would face-to-face? So that's payment parity. There are only a handful of states in the country that have achieved that, and largely that's because of organizations that have established a model for certain payment of services. So doctor on demand, those sorts of applications where I can go and do an online virtual visit at, let's say, $45 for a virtual consult. That kind of challenges their business model, and so they have concerns about that when they're being required to be reimbursed at a full rate for, let's say, a primary care or an urgent care visit, things like that. So it's important to understand what state you're operating in and what are the guidelines around commercial insurance, or perhaps what are the state laws related to telehealth reimbursement. And those can be complicated, but we have a number of resources such as the Center for Connected Health Policy, where you can go online and you can look at individual states and see what their reimbursement guidelines are for all three of those types of payers.
Thank you, Denny. Tammy, do you have anything to add?
I don't, because Denny is the king of reimbursement.
So let's break it down a little bit further, though. What about, in rural areas, there might be some different challenges. And I know some of the challenges around telemedicine are around staffing. So what do you think when you're setting up a telemedicine program, what staffing roles are vital, and how can you make sure that you set it up so that you get reimbursed for the staff time involved, such as a care coordinator or you know, a nurse who's doing that bedside work in the consult?
So good question, right? I think that when you're talking about direct to patient, it's not necessarily between telemedicine entities like clinic to clinic, right? So in that kind of scenario, clinic to clinic, you want a telemedicine coordinator who can kind of be the liaison between the two facilities, where they can coordinate services. Oftentimes we'll do a clinic day and time where patients will be funneled into a clinic Tuesdays from 1 to 5 p.m. and a telemedicine coordinator at each of the clinics helps facilitate how that works. And from the clinic perspective, then you're just bringing in patients, right, as usual into your schedule of the day, only they're being seen via video instead of in person in the clinic. When you go direct to home, it's kind of the same scenario, right? Whatever staff members that you're using to facilitate the patient being seen at your clinic, you're doing the same group of people who are facilitating direct to patient. The only difference is how are they coming into the virtual exam room? And again, that leans back to how are we sending the link to them, right? Scheduling the appointment in the EMR is the same. Scheduling the provider in the EMR is the same. The provider will often have some kind of a desktop icon to their virtual clinic that they click on, so it's easy for them. But for the patient, they need to know, okay, I'm ready, my appointment is set, how can I now enter that virtual clinic? And again, that's where the link and where that location is. So to tie the patient to your services, again, that patient portal is key because it's the place where they go and click on the link and then they're in what we call the virtual exam room.
Thanks, Tammy. Denny, do you have any comments on sort of how to think about how to make sure you set up your billing appropriately to have meet the staff requirements that you need for a telemedicine program?
Sure. So as I mentioned, certain types of providers get reimbursed for providing certain types of services, but oftentimes with telemedicine, we're not able to cover the services for the provider at the patient end. So as an example, in our world in telehealth, what we have is called a telemedicine originating site fee. And that can be billed for usually Medicare, Medicaid, and commercial insurers as well. But what that's intended to do is cover for the time and effort of the patient site in setting up and coordinating that consultation. So depending on the level of complexity of that patient visit, let's say it's a mental health patient and it doesn't require, other than rooming the patient, taking vitals and doing all those sorts of other things, documentation and check-ins that they would require. So obviously it doesn't take the level of resources that it might for, let's say, a telecardiology patient where we're going to listen to the heart sounds and facilitate the use of a stethoscope for the remote physician and those sorts of things. So oftentimes what we're faced with is that we have a provider that's able to bill, but not necessarily the same level of complexity and reimbursement for the patient, the caregiver at the patient end facilitating that visit.
Thank you, Denny.
And then also realize that if you're seeing the patient in their home, there is no originating site fee. But the people who are providing the services can still bill.
Thank you. Yeah, the billing piece is a really complicated piece to figure out. We're now going to take a minute to open it up for questions. So if anyone has any questions, you can go ahead and put them in the chat box. And we'll wait for just a second. Right now, I don't see any. Michael, do you see any questions?
No, I'm not seeing any at this point. We'll give them a minute.
Okay. I do see a question. or a chat? Oh, this is a good question. So the question that Pat has posed is actually, what happens if home health is the originator? The originating site, I assume.
So if home health is in the home and they can bill for services in the home, whether or not they connect an iPad or some kind of a video chat, is they're still being paid for their part of being there at the home. And then if a provider were to come in, they would be reimbursed, considering that they are able to do a telemedicine consult and they're the right kind of provider type. They would be able to bill as well. Correct, Annie?
Correct, you got it.
Thank you. Any other questions? Don't be shy. Well, if you think of questions along the way, feel free to chat them in the chat box. We'll have some more time at the end for additional questions.
There's another one that just popped in.
Oh, great. Thank you, Michael. For some reason, it's not showing up in mine. Can you read it, Michael?
Sure. It's that question is Washington State one of the states where we have commercial insurance party/payment parity?
So Washington State has coverage parity. However, we just had a bill introduced in this last legislative session. Unfortunately, it did not pass. So one of the challenges that we face is with health systems and their ability to negotiate their own contracts as well. And that's one of the issues that we keep bumping up against. I believe that was one of the contributing factors to the success of this one and then not happening this year.
Thank you. And these are all great questions, and it's a huge amount to untangle. There's one more question I can see. At home, why is there not a site fee if you have to send someone out to the home to hook a patient up? So an originating site fee at home.
So oftentimes when a patient is seen at home, in terms of follow-up care, there isn't someone else in the home. So they have the capabilities. They have some kind of a device, right? A laptop at home with a camera and a speaker and a microphone. They're able, through their internet, to connect to the provider to be seen. And they click into the virtual exam room just like as if they had walked into the clinic. So that's why there's no origination site fee at home, is that oftentimes there's not another caregiver in the home being reimbursed or specifically setting up the telehealth encounter.
Thanks, Tammy. I see another question. Is hospice the same as home health as the originator?
Boy, that's a good question, and I'm not able to answer that one directly. I'm sorry. I can check into that.
This is Pat. I'll just jump into there a little bit. Because hospice is capitated, because they're paid to deliver all services to a patient, my guess is there wouldn't be, this is my best guess, there wouldn't be an additional charge they would make, but they would be being paid similar to home health to be in the home through their capitated service to provide all care to that patient.
Thanks, Pat.
Here's a question. Somebody asked, home health can't see patients on the same day as a doctor's visit, correct?
And bill for that service? That's a good question also.
And some of these, we may not know, and I can go ahead and collect the questions and, try to sort out the answers afterwards for any of them that I'm not able to answer today.
Well, and I think also if that is the case, there's always ways to work around this, right? We take a look at what are we able to do and how can we make that work. And so if it's empowering the patient and the patient's family to be able to click on a link and see their provider maybe it's not on the same day that somebody else's home health is in the home. But unless it's something where somebody really needed to facilitate the connection for them, it's pretty simple to be able to connect today, just like we all have on our computers for this program.
You know, related to that question, actually, so the new Medicare rule that came out did have a timeline for seeing a patient. And I'm not sure if it's connected to the same question, but I'm wondering, Denny, if you know about the Medicare rule.
I believe you're correct. It has something to do with seeing a provider within 7 days of a visit, that sort of thing. And I can follow up on that.
Okay, thank you. Another question from Raleigh in TWISP. How do we really get started? Say, start with the provider to telehealth in the exam room in the clinic, or what do you suggest is a simple first step?
I think the first simple step is to follow your patients back out into the community. So again, existing patients, not new patients, somebody who has the capability to do that and the willingness, right? And so start following your patients or giving them access to you outside of the regular clinic appointment, which is a great way, and which is what we've seen successful so far.
And I would just add that I think it's really important to understand the provider's workflow and the patient consult workflow. What are the requirements for that consult that need to be accomplished? And then can that be delivered telematically with the tools that you have at your disposal? And then sitting down and looking at an appropriate workflow and testing that workflow.
Thank you. It looks like there's a hand raised on the side. Michael, can you unmute Ivana's iPhone?
Okay.
Hi. Can you hear me?
Yes.
Okay. So Pioneer Human Services provides mental health services to patients who are part of our PACT team, where mental health patients who have co-occurring diagnosis are residing in the housing unit, so sometimes in their own homes. What we are planning to implement soon is a model where our ARMP would be remote, and then another PACT team member, so we're talking all our direct employed staff, where another RN would be at patient's home. So we're utilizing two computers that are essentially our ownership. What my concern is billing, and can we bill for services of both ARMP and RN person, or I don't know if it can be anybody that is different than RN who is with patient at the time of connection.
So Ivana, did you say this was mental health, and was there anything,
Yes.
anything else like
SUD sometimes, so co-occurring diagnosis.
Okay. I'm not sure if you're aware that there's a new Medicare rule that's going to allow, and I want to say 2020, I'd have to double check, January, that's going to allow reimbursement for that type of a service for patients that are in the home. So we can give you additional detail on that. I think the challenge is, in the situation that you posed, was whether or not the nurse could be reimbursed for that service. So I think oftentimes, go ahead.
Yeah, we most definitely can seek reimbursement for ARMP who will be
Correct.
remote. Simply the scarcity of resources. Our own ARMP is moving out of Seattle, so we plan to retain her and provide service remotely. But the question becomes whether or not we can bill for that second person, and then we definitely don't need BAA agreement, and we don't have similar encryption concerns, like as if somebody was entering from their own home domain. But at the same time, you want to make sure that you're utilizing platform. And I'm wondering whether or not we can have some recommendations as far as telehealth platforms that are out there that are, not all animals are the same.
Sure. Tammy, do you want to take the platform question?
Yeah, I think that when you're talking about the platform question, it's really about what kind of software you're using and whether or not the software requires every person to have a license. So there's some software, maybe Ivana, this is your program, where we have 2 licenses assigned to 2 iPads or tablets, right? And that's a point-to-point connection. That is a feature of the software that makes it kind of HIPAA compliant in that regard. But to my knowledge, again, BAA with the vendor is a part of purchasing.
Oh, it's a must. Yeah.
Yeah, that you'd have to do. So other software requires, they're more marketplace software where, like, for example, Zoom has many seats at the table. Are there other features you can do between that kind of software for locking the conference or making sure that others can not come in or interrupt? So there's all sorts of ways to do it. In the realm of direct-to-patient, it's definitely a software we're talking about, not an appliance or hardware. So there's a variety of options on the table, but you just want to make sure that you've got features within the software that allows privacy, security, and again, that HIPAA BAA in place.
Yeah. Perfect. Thank you.
Thank you.
And then also, just one other
ahead.
thing, we were talking about Denny's comment about CMS, and I did find this one that said beginning July 1st, 2019, so right around the corner, origination site geographic conditions adds an individual's home as a permissible originating telehealth services site for treatment of substance abuse disorder and co-occurring mental health disorder. So again, reimbursement from CMS into the home will help that.
Perfect. Yeah, we're aware of that, and
okay, I'm sure
that was
everyone who's in the telehealth story watches all the release notes of what's coming next.
And that's a huge step for CMS.
Yeah.
Well, there is such shortage of stuff, and our struggle is real.
Yeah.
Yeah.
Thank you.
Well, so thank you. We need to move on to the next part of the webinar. Deb Watson from Pullman Regional Hospital is going to present a case sort of sorts of how they're planning or hoping to set up a telemedicine program. And Tammy and Danny are going to talk through, what are some of the questions and issues and how to set that up. So I'm going to turn it over to Deb now to present your case.
Thank you, Bonnie. So we are trying to expand our inpatient palliative care service that is naturally kind of morphed into an outpatient service with follow-up to the patients once they have discharged, or their family or their caregivers, via the phone. And our palliative care team is really limited in their ability, their hours that they can dedicate to the palliative care work and the follow-up phone calls. And so we're pretty much at our maximum capacity with 17 patients that we have that we're currently following. And as those patients drop out or pass, we are adding new patients into that kind of caseload. But we really are interested in seeing if telehealth could perhaps either enhance our follow-up care, that it would be a better contact point versus the phone calls that we currently make. And could we actually expand our service in like a second phase or second wave to actually become reimbursed for some of those services? So we're kind of thinking of a two-phase implementation with it. And we have a lot of questions about how we might expand into the telehealth realm. The first goal that we would have with this phase one is to be able to provide goals of care conversations to our patients and or follow-up care instead of using the phone always. And the goals of care, we have a number of patients that actually meet palliative care criteria. They screen in using the form. However, our team is limited at that point in time, and so they're unable to provide any in-house service while they're admitted to the hospital. And so they would like the option to be able to consider some of these patients that screen in and would like a goal of care conversation, to have that conversation take place from the patient's home. And so we're wondering, can the Zoom platform be used for that? The hospital currently has access to Zoom. And if Zoom can work for that, kind of how does it work? And are there additional pieces that are needed that are going to add cost into it? I'm gathering by some of our previous conversation or responses by Denny and Tammy that there may be some components such as figuring out whether they currently use Meditech as the EMR, and does the patient portal allow a space to place a Zoom link that the patient can access from home? So that I know that's one thing that we're going to have to consider. But if Denny and Tammy can kind of expand on how might Zoom work for us for this expansion.
Super exciting, and happy to see people who are interested in going forward with offering services via video. So yes, any kind of software will work, right? You just need to empower patients and providers to be able to have a space where they can see one another. I think Goals of Care is a great place to start. And in my opinion, a picture paints 1,000 words, or however that saying goes, because I think about, if I am talking to you, I can see how you're responding to the issues that I'm bringing up. If I needed to share a screen or something that I wanted to show you, I would be able to do that. So, you know, you think about how you talk to people in person, and often it's like, well, wait, look at this, or have you considered that? You know, that you can do all of those same things, including sharing a video if you wanted to, right? So the quality of conversation that can occur over video as opposed to a telephone call can really be enhanced and really be a tool that can be used to engage people. So having said that, could Zoom work? Absolutely. I know that you guys have Zoom that you're using at your facility. The Zoom room is one place, right? And then we also have Zoom licenses. Please note that I think it's through meaningful use, every EMR has a patient portal today. That means that every patient portal has a message box. And again, in order to be able to place a link in a message is just, do I know how to do that? As a patient, can I open this up? And, you know, do I know how to log into my portal, get to my messages, and click on a link? Those are just logistics, right, of how we do it. It's, can we do it? Absolutely. How do we do it is that question. We help people kind of work through those pieces of how do we do it. If it's just any Zoom license, because let's face it, Zoom has free licenses, right? Can anyone just click on that? Well, not in the world of healthcare and HIPAA. You'd want a pro license. Pro license has certain features that you can manage, like locking conferences so that other people cannot interrupt a consult. Like, you'd never leave the door open in the exam room, right? When the patient comes in and you walk in, you shut the door. So I always view locking the conference as shutting the virtual exam room door, which I think is really important. So part of it is just, you know, how do we manage those accounts? But then also, in order to get that BA, I know that Zoom requires 10 licenses. So right off the bat, there's an investment in what you're doing in order to provide services. So that's when I circle back around to, what's the goal for the amount of people in your facility who are going to be working and offering services? What's the logistics of providing links? Would they be the same, or different? So it's really a bigger conversation of coordination and structuring how your program will work, so that we can really understand the costs and the requirements on providers and patients to meet.
Thank you. That was really helpful. So moving just a little ahead of that, but it's really behind that, is an iPad the best option? And is the better option for the hospital to figure out a way that we would actually loan these devices or provide the devices to our patients versus having the patients use their own devices? Is there any thoughts about that?
Yeah, no, I think that's a big piece. So when I think about tablets or anything going into a home and giving it to the patient, I'm not sure that that's the best scenario. It's one thing if it's remote patient monitoring, you're having tools that feed back automatically data and information. to me, that makes complete sense. But something that's just the virtual connection, a talking space where we can have a conversation, I'm not sure the expense of that iPad would make sense. If you have somebody already going into the home or somebody needs to facilitate that for a compromised or delicate patient, absolutely, right? So think about who your patient population is and if it actually makes sense to have somebody coming into the home. Otherwise, most people in today's world, not everyone, but a lot of people have some kind of device where they can connect. And we can certainly, because of the quality of phones and connectivity today, we can certainly get a catchment of a large group of patients who might be able to do that. I think knowing your patient population and understanding where they are and then choosing technology appropriately is kind of part of the process of assessment.
Okay, thank you. So you brought up connectivity, and most rural locations and the Whitman County area is just like most rural locations, and we do have some issues with connectivity. So how good of the connectivity does it have to be to support a platform like this? And how might we be able to test or figure out in our county and spreading into even Idaho, some of our patients live in Idaho, that the connectivity is there for us to even do this? Is there a way to figure all that out?
So one, you want to pick, when you're looking at software, you want to pick something that has a dynamic bandwidth. So a lot of software today is intuitive, right? So it connects out and it takes a look at what bandwidth is available and it adjusts down. So it's anything that's dynamic in how it connects is key. Zoom can go down to 1.5 megabits, so really a pretty small bandwidth and still maintain the connection. I want to say that Zoom does have, it puts video first. So oftentimes software is arranged so maybe audio is first. What's the primary connection? I think Zoom has done well with their ability to put video as a primary connectivity within the software. So you usually get a good experience in terms of patient to provider, even in lower bandwidth areas. Because we've experienced implementing quite a few direct-to-patient programs now, we've not only offered this certification process, and if you didn't have someone like me to offer that, could you create something where someone would test from your clinic to the patient prior to the provider? I would say that would be a good idea because you don't want to waste the provider's time and you don't want a bad experience, especially when you're trying to create a new care delivery system or method. You want people to be successful. Having said that, we've already jumped forward to, can we give the patient a piece of paper that says, here are the requirements and here's how you can self-test? The answer is yes. So especially, we do it for everyone, whether it's an administrative meeting, an educational program. If you've noticed as attendees, if you registered for this program and the question was, have you ever used Zoom before? And you said no, chances are Pam in our office sent you a little sheet that said, here's how you test your connectivity speed of your internet. Here's how you can connect to Zoom. Here are the requirements for participation. We can do that, which means that the patient's empowered at home to click and test a link that tells them how their bandwidth is. Those are things that we can sort through prior to any first care encounter so that we're pre-qualifying or the patient knows. And oftentimes patients will try and there'll be a problem that we either can or cannot resolve, and sometimes you're just not a candidate for being a virtual care patient. And then in that case, we identify it, we say, but there's a clinic close to you, and perhaps you could go to the clinic, and if your provider's at a longer distance, and we can touch point with you there. It's one of those ebb and flow depending on the scenario and how best we can achieve our goals of getting access from home or from clinic, wherever the next best place is.
And the only thing I might add to Tammy's conversation is that oftentimes when that patient's in the hospital and they're getting ready to go home is an opportune time to meet with that patient and discuss telehealth, maybe have a conversation about what their connectivity is or what kind of device they might be using. Particularly if you know that patient, you might be communicating often with them and they're perhaps a frequent flyer, or you'll need to reach out to them often. So that's a perfect time to set this up versus trying to schedule it when they get home, which is particularly challenging.
And that's a very good point, Denny. And the other thing you can ask are simple questions like, do you watch Netflix at home? You know, if the answer is yes, there's that download of, internet that you go, well, if you can watch a movie, then chances are you can talk to your provider. So there's definitely ways that we can have a conversation that people can relate to. Because if somebody said, what's your bandwidth at home? I'd be like, I have no idea what a bandwidth is. What are you talking about? I mean, I had to learn what that was. But if you can relate it to just some basic things that people do, that's a great way to qualify whether or not they have capabilities.
I like that. Okay, and I like, Denny, your recommendation about trying to introduce it and set it up ahead of time before they discharge. That's a really great recommendation. So what are some other things that we should consider for ensuring a successful telehealth session? The connectivity needs to be there. They need to have the device. They need to be able to go into the EMR and click on a secure link. What else should we consider?
Yeah, I think other than that, you want to consider the experience from home. So what we tell people is when you're at home, don't have somebody watching Netflix at the same time you're trying to do a consult. We've had scenarios where in the house they're sitting tends to affect the internet. So if your router's in the kitchen and you want to do it up in a bedroom off the second floor on the other end, and there's a problem with connectivity, move your device closer. So you'll be able to tell kind of where is the best place. For sure, we want to make sure that there's no bright window behind them so that they're silhouetted. You want to make sure that it's relatively private, right? You're having a private conversation. So, I guess every now and then the cat coming across the screen is adorable because Fluffy's cute, but, try and put it in a space where the pets and the kids and all the craziness are not occurring. And that people really have kind of a private moment, just like if you'd shut the door and have a conversation with your provider. And same from the provider's perspective. Again, some location, oftentimes in a clinic, they'll have a room where they've got a video-enabled computer or an appliance or something, and that's where they do their telemedicine consults. Sometimes it's from a provider's office. It certainly can be in any of those places. But when you're thinking about a facility offering services out, I love the idea of having kind of a space where anyone who's providing care in that service can come in and access that camera, because then you're not repeating on multiple computers, cameras and software and headsets and the things that might make it best in terms of a successful experience. Danny?
I would say that probably one of the most important things to think about is your workflow. Obviously, when we're doing a consultation between a provider and a patient in a hospital or a clinic, we want to focus on replicating the normal workflow as much as possible. But now when we transition to the home, that's a bit of a different matter. We might have a caregiver there, we might not have a caregiver there, but by paying attention to the workflow and testing it thoroughly and revising it as needed, we can make sure that that's a practical, efficient way to conduct a consultation. Also, it's important to think about when things go wrong. We might lose connectivity. What's our fallback? How are we going to deal with that? Do we have support mechanisms, whether it be IT or otherwise, that can help us resolve technical issues and things like that? But I would say a functional workflow that is well-oiled and works is probably one of the most important things that we need to think about.
Thank you. So we touched on this a little bit about when we should consider sending someone out to be with the patient or the family to help them either set up. So help me understand what circumstances require this. When would we need to think about sending someone out to be with the patient and or family?
I think it's probably important to consider the level of acuity of that patient visit. What's actually required? Do I need to collect vitals? Do I need to facilitate an exam of some sort? Am I doing something special where I need to have a resource in the home? Obviously, the way we live today, resources are constrained. We're challenged with the level of resources available at our disposal. We need to be more efficient. And that's not always an option. So we really need to think about, is that necessary? Perhaps it's necessary for the first or second visit if we know this is going to be a frequent occurrence. So we can think about doing that as well. Maybe they facilitate the first or second exam and then move on from there, and the patient's more familiar with it. We might have family involved, and how do we facilitate that type of an exam where we have multiple people involved in a conversation, or relying on a family member to show us something or talk to us about something. So you kind of have to think through multiple scenarios and what might be required at the patient end. And the last thing to think about is the safety of that visit. Are we doing anything that might jeopardize the safety of that consultation and put us in a situation where we might be more at risk? So I think those are important things to consider.
I completely agree, Denny. And the only other thing I was thinking of is if we're talking about technology and bringing it in, and when does it or doesn't it make sense, if you have some kind of a tablet and you're providing the connectivity because there is poor connectivity into the home or not available, you can always have Wi-Fi hotspots on something that you're bringing in and connect to a patient in that scenario. So again, where are the goals of care here, and what's the benefit of going to that level of actually offering services into the home?
So if we were to need someone to go into the home, what type of role, given what type of need in the home, I guess, would depend on the person that we send out? Is that so? If vital signs were needed, they would need to be someone who could accurately take vital signs?
Absolutely.
Oftentimes in telehealth, we use telehealth trained individuals, and we call them telepresenters. And those folks are typically trained in how to use technology, how to facilitate a particular type of exam, let's say telecardiology or something like that. And then they're well familiar with the process and the protocol that we're using. So I would say, think about what you're requiring for an in-person visit of that type, and then is it necessary at home for what we're going to do to replicate it in that environment? If it's not necessary, then we probably don't need to think about doing it.
How have other people gone about training the telepresenters? Is there like a standard kind of format for a telepresenter, or does that vary depending on the services that you're going to provide?
Right. In our organization, we have pretty much a certification program where we train telepresenters in how to use the technology and how to do it for specific exam type of things, how to do it safely and effectively, how to present the patient to the provider in the most efficient manner, positioning, lighting, using stethoscope, those sorts of things. So it is really important to have them understand it as best they can when they're with the patient, particularly for higher acuity things.
And actually, I'm going to jump in here real quick, Deb. We did a couple of years ago a webinar on telepresenting, sort of the basics and what it is. And we have that available, and we will put it up on the portal for anyone who likes to see it. I think it's already there, Pat, Cassie. Pat's nodding. Yes, I think it's already there, but I will direct you to it so that you can find it. And there's a lot of, I think, online type of trainings as well for telepresenting. So it's almost 1 o'clock, so I wanted to ask Deb if you have any other questions for Tammy and Denny, or if anybody else has any other questions they want to ask real quick. We probably have time for one question.
I will let others ask.
Thank you. Thank you for presenting your case. It was really interesting.
Thank you for letting me.
Thank you. It was great. I think Denny only has another minute or so. He's got to jump on another call, but he did such a fabulous job, so I wanted to thank him for joining us. But then also, I had one question that somebody was, please explain 10 licenses. If we had 10 licenses, we'd be able to reach 10 patients. A license, again, you can do multiple patients. You'd need one at a time, right? So if you want to see 2 providers and 2 patients at the same time, then you'll definitely want to have more than 1 license. But in the case of Zoom, it's not a requirement for the patient to have a license. So again, the difference between am I purchasing licenses for each side of a device, because I'm going to go into the patient home, is different than if you're going to just offer a link up, which does not require the patient to have a license. I hope that answered the question.
Thanks for clarifying that, Tammy.
Mm-hmm.
So we are actually out of time, but I know Tammy and Denny are probably available for follow-up questions via email. You can contact me anytime, or Pat anytime, or Deb Watson, and we can help facilitate your questions if you can't reach Tammy and Denny directly for some reason. So I want to thank you today for speaking, Tammy, and it looks like Denny left, but I want to thank him too, and also thank Deb for being willing to ask all the questions that a lot of us have. From her own perspective. So thank you, and we will see you on the next webinar.
Yep, thanks everyone. Appreciate the opportunity.